Thank you so much. Now, the next speaker is Dr. KSHAMA DWIVEDI, is going to speak on the pterygium. With the cataract, there is a lot of confusion, though Dr. T.P. Ilhane had very rightly said that the first do the pterygium, then followed by this cataract surgery. But Dr. KSHAMA DWIVEDI, in detail, she is going to talk and discuss why this surgery, which surgery should be done first, and he is also excellent oculoplastic surgeon. And in front of Dr. KSHAMA DWIVEDI, her guru and teacher is present, Dr. R.P. Maurya. He will definitely will make request to share his experience about this talk and give some of the tips to the audience, especially the youngsters. Thank you very much, Dr. Start.
Thank you, sir, for your kind introduction. Good evening, respected seniors and dear delegates. I would be talking about SICS with coexisting pterygium. Now, why is it important? Because nearly 1/10 of new OPD patients, they have pterygium in at least one eye, and half of them have coexistent cataract. Both of them have UV radiation as an important predisposing factors. So should we always deal with them simultaneously? It is just to show what is the magnitude of problem. As we go towards South India, the incidence of pterygium goes on increasing just as proportionate to the UV radiation. Concern with pterygium is due to the...
R.P. Maurya to come with me. I am alone. Please come. Please.
Concern with pterygium...
excellent teacher. Sorry, excellent teacher and academician par excellence of national and international depute. Please come and share your experience in front of us, please. Continue, please.
Thank you, sir. Concern with pterygium is due to the pterygium-induced astigmatism, which affects the IOL power apart from cosmesis. And studies have shown that even a grade 2 pterygium may induce about 3 diopter with a rule astigmatism. And excision of pterygium will affect not only both the meridian but also both the corneal surfaces. Persons who are predisposed, they are usually from the lower socio-economic strata, and if you unattend the pterygium during cataract surgery, it will increase the chances of refractive errors post-operatively. So what is pterygium-associated astigmatism? It is the sum of pre-existing astigmatism as well as the pterygium-induced astigmatism, and they are independent variates. Usually when we perform cataract surgery in older patients more than 50 years, they have against the rule astigmatism, whereas pterygium induces with the rule astigmatism. So there may be situations that the patient's own astigmatism may be neutralized by the pterygium-induced astigmatism. So what factors it may depend upon? You can decide how important the pterygium is for that patient in sense of astigmatism by the horizontal length. It was classified by TAN, by surface area, or by vascularity, which classification was proposed by Sang. We have another comprehensive classification proposed by Johnson as well, which takes into account multiple factors, because not a single factor will determine the astigmatism induced by pterygium. All these are taken into account. Now, refraction is difficult in pterygium because the changes are in one meridian, that too half of the meridian. So this hemiastigmatism is difficult to measure, and due to its hemiastigmatism nature, the acceptance of cylinder is further poor. Keratometry measures only the central 3 mm of the cornea, so topography is the best. But in large pterygium, topography is neither feasible nor required, as sequential surgeries is mandatory. Pterygium-induced astigmatism is reversible except when you have corneal scarring, like in deep pterygiums. And you should repeat the keratometry after 4 and 6 weeks to look for stability of cornea. Period required for stabilization may vary depending upon the pterygium. Now, how much change do we expect? It is positively correlated with preoperative grade of pterygium as well as a preoperative astigmatic value. So higher preoperative astigmatic value, you will get a larger postoperative change. There's a technical glitch if in case you perform a bare sclera, you detect more steepening on topography. It is simply when you perform the bare sclera. But otherwise, if you have different modes of graft fixation, there is no change in the individual modes. Sequential has always proven to be better whenever you are performing cataract and glaucoma or cataract and endothelial keratoplasty, and same is true for cataract and pterygium as well. But we should prefer to do it simultaneously, especially because it reduces the hospitalization, it reduces the cost for the patient, it reduces the burden on the hospital. So if you have a small pterygium, if you have a patient with low or absent astigmatism, they are regular mass and regular central corneal curvature, then they must be operated simultaneously. Now regarding the graft harvesting, you can harvest from the superotemporal bulba conjunctiva. Definitely that is the most preferred area. But since you have to perform the SICS surgery as well, so sometimes harvesting a graft from that area becomes difficult. So what other options you have? If you have access to amniotic membrane, wet or cryopreserved, any of them will do. Some people have proposed isolating the conjunctiva from pterygium tissue as well. I recommend if it's a thin atrophic pterygium, very well you can go and isolate it from the pterygium itself. But if it is a thick fibrosed, thick fleshy type of pterygium, it gives a very bad cosmesis if you use the tissue from the pterygium itself. Now what should be the position of the tunnel? If you have a superior tunnel, it will negate witherul astigmatism to some extent. If it is a double-headed pterygium, you have to go superiorly. In superior conjunctival scarring, or if you have less than one diopter of witherul astigmatism, you have to perform a temporal incision. Or whenever you are performing any surgery, look for scleral thinning and just rule out that area. Incisions has to be watertight, and if there are any leaky incision, please suture them. And we choose to avoid antimetabolites. The IOL power change during the simultaneous surgery has been proposed differently by different authors. What we practice is we reduce IOL power by 0.5 in grade 2 and by 1 diopter in grade 3, and they usually perform very well. There are also various regression formulas available for the IOL calculation which you may use. Regarding the astigmatism management, if it is a simultaneous surgery, we don't perform any astigmatism management because the results may be unpredictable, but you can perform the incision on the steep axis, and in sequential surgeries, the method of astigmatism is same as in any SICS. So this was one of my cases where it was TANS grade 3 and SICS grade 2. So this is a keratometry. Prior to the pterygium surgery, you can see the vertical meridian was steeper. These photographs were taken from the keratometer. Topography was not feasible because pterygium was invading almost up till the pupil. So we performed a conjunctival graft with electrocoaptation, and this was the corneal topography 1 month after the pterygium surgery. You can see actually that the vertical meridian became flatter now, and it was a horizontal meridian which became steeper. So now we performed the cataract surgery 1 month after pterygium surgery, and we placed a temporal incision, and that was on the steep axis we placed the incision, and so it flattened the horizontal meridian a bit, and so the astigmatism was minimized. So this is how you can plan, and you can actually control the astigmatism just by pterygium surgery and planning your incision on the steep axis. So in conclusion, I would like to say sequential surgery is better than simultaneous surgery as it prevents the post-operative surprises, but definitely if the patient is a candidate for simultaneous surgery, you can do simultaneous surgery as well. But if you want to do simultaneous surgery in candidates who are not fit in the criteria, always remember to reduce the IOL power, and please don't attempt astigmatism management and simultaneous surgeries. Thank you. Now yes.
Thank you, Dr. Samadevit, for an excellent talk, a very good information. As you know, nowadays cataract is not a simple cataract surgery, but is rather as a refractive cataract surgery. the main is, you have to take care of the astigmatism. Means the main aim is how to provide a good vision near to the normal, that is 6 vision, and you can achieve only by controlling or managing the astigmatism part, either it associated with astigmatism or the pre-existing astigmatism or surgically induced astigmatism. You have to, if you take care of this thing, this is as good as the phaco. There is no difference. If you are able to provide, manage the astigmatism, then there is no difference, not at all, in the SICS or the phaco surgery. Might be some difference with the ECC, where the sutures you are applied the suture, but once you are doing the SICS, this wound is as strong as the normal eye or the phaco. So the only question is the length of the incision of both the phaco and the SICS. So estimated part, so very nicely Dr. Samad has enumerated and described the very things, how to control astigmatism, when to do, when to operate. Thank you very much. You have any questions?
Thank you, sir.
This.
Usually 4 weeks are sufficient for after pterygium surgery, but if you see there are significant change between second week and fourth week, maybe you can wait for 15 days more. 6 weeks is enough. Thank you.
Now I request academician Dr. P. Moria to make some comments.
Thank you, Dr. Sama. Nicely presenting cases of pterygium, simultaneous surgery of pterygium and SICS. Pterygium as well as SICS, both is an important topic concerned for youngster and beginners. But I am saying that the management of pterygium is not very simple. Pterygium concerned with the vision as well as astigmatism. Similarly, SICS, perfect SICS also give good vision equally as the phacoemulsification. There are so many techniques to manage the pterygium. It depends on the types of pterygium, whether it is atrophic, whether it is recurrent type or malignant pterygium. But pterygium surgery of the pterygium along with the SICS is, I think it is a very difficult, and it needs expertization, and then one can do the both simultaneous pterygium and cataract surgery. Otherwise, just Dr. Lehane says that start pterygium first, then start the SICS for beginners.